That's our second panel for today. So we'll kick off. Without much ado, I'd like to start with Temi. People fired up by the first panel thinking, yes, I'm going to go and do that. What are the things you want to say before you do that? These are the things I wish I had known.
So, right. Hi, everyone. So Live Bank actually started in a hackathon like this about 4 years ago. So it was originally my side project. We had an hackathon here at CC Hub, exactly the same place, and we built something called the Live Bank app. I was running a small NGO on the side at the time, and we built Live Bank. It was supposed to be a donor matching platform. So if you're a doctor in a hospital and your patient needs blood, you find a donor to come and give blood for your patient. Now, so that was the first iteration of what Live Bank is right now. My company is what your idea could be in a few years. That's how I think about it. But you have to, a few things, you have to validate the idea in the hospital. So the first thing you do is get your MVP. I think you can get the MVP from this hackathon. Then you just go spend some time talking to your customers and figuring out exactly how they will use it and what they need.
Thank you very much. I'll turn to you, Ezine, since we're talking about technology and you've been trying to work, to get people to use some of the solutions that you've come across. What have you learned from that process? What's worked? What hasn't? And where are there still gaps that you feel from your experience so far?
Thank you so much. So my name is Ezine Anyao. I'm the CEO for EpiAfric. Working in the US system, everything was digitized, everything was computerized. And so that was where my first love for health and tech started. For those of you that will be in this hackathon, I want you to really understand and really think of it in the sense that you also have to think beyond your applications. We believe in solutions that's software and hardware. So we're not just giving software, which here in Nigeria, they still find that you haven't left something behind. You almost have to have a hardware attached to it for them to really feel like you've delivered something to them. We are creating or presenting products to humans. We're not building tech for tech. We're building tech for humans that do have to take care of other humans. So if we don't understand what their needs are, if we don't spend time talking to them, it can be the greatest technology in the world. And I mean, in the US, UK, everywhere, they have great tech that's working. But we come to Nigeria and we're like, wait, it's not the same. So I think for challenges, you really have to look at your infrastructure, especially because if that's not in place, the technology is really not going to do what you want it to do. So people, process, then the technology, and then repeat it again. Because once they start using it, you just don't say, okay, they're good. You have to go back and address, because people issues are going to come up. Processes are going to come up. And that's kind of how you have your first iteration, second iteration, 2.0, 2.5, again. So you have to kind of keep that circle going.
So Remy, what are the things from the journey that you would like to share? Again, not all looking at creating solutions, but just thinking about what some of the problems that you think, I wish we could sort these things out.
Yeah. Thanks very much, Ike. Nigeria is best for people who can persevere. Persevere with a vision, persevere with the optimism that something big can happen here. So that perseverance combined with your passion and endurance is very, very, very critical to success. The goals of healthcare are very simple. Of health, you want access, both physical access. Do I know where the next ENT surgeon is? My brother, who is a banker, called me one day. You're in the space. I have a very bad ear pain. I have a meeting in 4 hours. I need someone to see me now. It's in VI. I start to call all the people I know in Luth. Now, imagine that I need a hotel in VI. I just go to any of these various hotel apps, and the tens and hundreds of hotels in VI will come up. The same thing we need for health. What are the facilities that are present in each location? So we talk about the DIC and the need for us to incorporate DIC. Data must be transformed into meaningful information, and it must be converted into actions that will benefit the things that we all live for in health: longer life, and not just the absence of disease, but full physical, mental, and spiritual, and whatever else. So we can have all these things, and you will see that it will create a platform model. When people are using your platform, that's where your revenue comes in. And that's the kind of things we should be looking at. Not what the problems are per se, but benchmarking. What is working well in other sectors that we can bring into healthcare?
Thank you very much for that, Remy. I'll now turn to Nkechi. You've had experience. What are the things that you think we need to highlight, focus on, think about?
Last year, in my health insurance life, we carried out a survey, and there were 3 things that came out from that survey. And it was really asking the customer, what is it that you want right now? Because between the last 2 years, quite a lot has happened in the health insurance space. It appears that the customer who started out being just very excited that we could tell him to walk into any hospital, access care, you don't have to pay, was no longer excited by that. He wanted bells and whistles. And we were consistently, bending over backwards to, he says he wants this bell, we give it to him. And then just before we're even done, serving it to him, he's asking for something else. So it was like the landscape clearly had changed. They don't want to have to, you get to the hospital and there's a long queue and then you have to wait and then the vitals and then, there are masses of people waiting. You leave the office, you have no idea when you're going to come back. So speed, 1. Number 2 was also convenience. Somebody was talking about the fact that you can do so many things on your mobile phone now in terms of banking. You can send money, you don't have to go into the banking hall if you don't want to. And so they said, we also want convenience. Why can't we have it conveniently? Why does it have to be the way that you want it? And then the final thing they said, we want all of this, but guess what? We also want it at a fraction of the costs. We want it really, really, really cheap. A customer says, I want convenience. That means I don't want to have to leave my house to see the doctor. Then telemedicine begins to come in. And it can no longer be, because in Nigeria, every time you talk about it, it's almost like a dirty word, before the clinicians. How can you take away the personal doctor contact? But hey, that's what the customer is beginning to ask for. And we do know that there are some of those ailments that, yes, do not qualify for telemedicine, but we do need to have a ranking list of those particular ailments that can qualify for telemedicines. And so people can, in the privacy of their home, the comfort of their homes, actually see a doctor, not just in Nigeria, but anywhere else in the world. One of the things that lead to major costs in the healthcare sector is the duplication of services. We've talked about referrals. So patient is referred from hospital A to hospital B. When he gets to hospital B, all the investigations that were done in hospital A just get repeated all over again. And so that duplication leads to quite a lot of wastage. And of course, in the health insurance sector, what that means is that when we're reviewing your numbers for the next insurance year, we're saying that we spent so much money on you. We can check to see, okay, did that come from lab investigations or whatever it is? But ultimately, what that means is that you're going to pay a higher premium. Dr. Coker spoke about electronic medical records. This is used worldwide, except in Nigeria. But there has to be some sort of electronic interface between the hospitals and whether it's the health insurer, the health information exchange, or whatever else it is.
Thank you very much. That's very extensive and very helpful. I think we've heard a lot. I'd like to open it up to the audience again. Gosh, all the hands are coming up already.
How do we reach these 180 million people with solutions that are helpful for them? People that are in the village with the techno, not even techno. So we need to have to reach them.
And so in the mobile aspect, absolutely, smartphones are great if you're in Lagos, but when you're going out to Kafanchan and Vom, and MTN is not working, Glo is not working, Swift is not working, nothing is working, but there's a lot of people there. So we start asking them, where do you go and get care? How do you get care? So that's sort of like, we have to think about our technology inclusively if we really want to make a change.
How do we start to develop mobile technologies that will be able to help with public relations in the health sectors, help with community relations, being able to, deal with the patient like, oh, this person is a real patient. Maybe when we start to do that, the idea of adoption, acceptance, sustainability will start coming into play. Thank you.
Artificial intelligence is coming. If you're a doctor, you don't like artificial intelligence, you should start thinking about how you're going to work with it. It is coming. It is coming to Africa, and it's coming with and it's one of the ways we can actually help solve some of the problems we have. If you don't have enough doctors and you have a lot of patients who are poor, best thing is to just deploy artificial intelligence around the clock with doctors who can manage it and who can give one-on-one care. So it's coming. Get with the system and let's build together.